Hello, my name is Adam Watts, consultant elbow surgeon from Wrightington Hospital and member of the NJR editorial board. I've been asked to talk to you about the evolving picture of shoulder and elbow arthroplasty from the NJR. Shoulders and elbows have been included in the NJR since 2012, and this now makes up one of the largest data sets worldwide. A major project to reclassify shoulder arthroplasty was undertaken by Oxford University, and this will improve the reporting of shoulder arthroplasty going forward. Similarly, shoulders and elbows are now going to be included in the live audit by the NJR from 2021, which should improve reporting going forwards. When we look at the shoulder arthroplasty cohort, there are 45,784 shoulders included in the revision analysis. 70% of these patients are female in the elective cohort and 77% in the trauma cohort, with a median age of 70 years and slightly older mean age in the trauma cohort of 74. There's been a changing trend in the types of arthroplastic procedures performed since 2012, with a decrease in the use of hemiarthroplasty, which now makes up less than 10% of all shoulder arthroplasty procedures. At the same time, reverse polarity arthroplasty has increased in proportion, possibly even at the expense of anatomical shoulder arthroplasty since 2015. The major indication for shoulder arthroplasty is osteoarthritis, and in this cohort, anatomical replacement is the most commonly performed procedure. For most other groups, reverse polarity arthroplasty is the most commonly performed. So that's in acute trauma, in cuff tear arthropathy, trauma sequelae, and inflammatory arthropathy. The NJR has been reporting shoulder volumes by unit and by surgeon, and since 2016 there's been very little change, with about 14 cases per annum per unit and 10 to 11 cases per surgeon. There's little change in the revision rate compared to trauma and elective cases for shoulder arthroplasty up to 2 years, after which point there does appear to be a divergence in the revision rate. However, the numbers at risk in the trauma cohort are low, and therefore we do need to be cautious in interpreting this data. When we look at the different classes of shoulder arthroplasty, there's one group that appears to stand out, and that's the stemless reverse shoulder arthroplasty, which appears to have a higher revision rate. However, again, the numbers at risk are extremely small, and we should be cautious in interpreting this data. What does appear clear is that there is a difference between hemiarthroplasty groups of patients and those having reverse shoulder arthroplasty and anatomical arthroplasty, which as a group have broadly similar revision rates. There is also a difference in the indication for revision. In proximal humeral hemiarthroplasty, the major indication for revision is cuff insufficiency, and in the reverse polarity group, the major indication is instability or dislocation. PROMS scores are collected in collaboration with the British Elbow and Shoulder Society and the NJR. However, reporting of preoperative PROMS scores is low at only 25%, and while the rates of capture increases to 45% by 5 years, this data is not helpful if we don't have preoperative data to compare to. It's also very important to recognize that these low proportions of patients that we are capturing PROMS data for may not be truly representative of the whole cohort. Those for whom we have PROMS data have a lower rate of revision than the general cohort of shoulder arthroplasty. It is also important to recognize that the Oxford shoulder score does have a ceiling effect, with clustering around the upper end of the score, which is at 48 points. What we can say from the Oxford shoulder score is that 5% of patients report worse scores than they had preoperatively, and that the change in the Oxford shoulder score is lower for the hemiarthroplasty group than for those having total shoulder arthroplasty and reverse shoulder arthroplasty, which are broadly similar between those two. Unsurprisingly, there is a difference in survival rate or mortality following shoulder arthroplasty between those having surgery for trauma indications and those for elective surgery. When we look at elbow arthroplasty, the numbers are much smaller at just 4,373 elbows. However, this is the largest cohort worldwide. The average age of this cohort is the average age is 68 years, and 70% of the patients are female. There have been some changes in the reporting with a steady increase in the number of total elbows reported and an increase in humeral hemiarthroplasty. However, this data has only been reported since 2018. Radial head arthroplasty rates have steadily increased, and it's not clear whether this is due to a true increase in the number of radial heads or just better capture of events that are occurring. When we look at primary total elbow arthroplasty, there's been very little change in the indication for primary total elbow arthroplasty, with 50% of cases being performed for inflammatory arthropathy. This compares to other data sets worldwide where that rate is around 25%. Equally, there's been very little change in the number of procedures performed per unit and per consultant, with those figures remaining at a median of 2. When we look at revision rates for total elbow arthroplasty, comparing elective and trauma indications, there doesn't seem to be a significant difference in the revision rate. Again, numbers in the trauma cohort are low, and while the curves do slightly diverge, we should be careful in over-interpreting this data. The primary indication for revision is aseptic loosening and infection, and that's the same for both elective and trauma indications. Again, unsurprisingly, the mortality after total elbow arthroplasty is higher in the trauma cohort than it is for the elective cohort. What is interesting is the markedly higher mortality at 5 years after elbow arthroplasty compared to other types of arthroplasty. And this is largely a reflection of the high proportion of patients with inflammatory arthropathy. So in summary, the NJR is reporting increasingly useful information for shoulder and elbow surgeons. Inclusion of shoulder and elbow arthroplasty in the live audit from 2021 will improve the quality of the data, which is especially important for low volume procedures such as elbow arthroplasty. It's really important that we improve the preoperative capture of the Oxford Shoulder Score to be able to make better sense of the postoperative data that's collected. And there do appear to be changing trends in surgeon choice of procedures, which we will need to monitor and study the effects of this going forward. Thank you very much. And I'd like to acknowledge Johnny Rees from Oxford and the team from Bristol University for their work on producing the report this year.